Well, if everybody can take their seat. So we had, I think, an exciting and informative morning. I certainly learned a ton from the morning. And as we were putting the speakers together, the topics were thought, well, it may not be totally melanoma specific, but, you know, the gut microbiome we may want to hear something about. And you heard, here's Dr. Gardner talking about propranolol and the coral reefs, and I thought that their presentations were superb. And you can see why I invited Dr. Agarwala here, because that man can connect. So I was really delighted he was here. So we have an exciting afternoon, and we have, as you know, the theme of this is science to survivorship. We think that those can be equal parts of making someone whole again. Most doctors and providers focus on the treatment aspect and the prognosis aspect, and not about the life aspect very well. So we're going to cover a couple of topics this afternoon before our patient stories. We have at least two, and I think our third patient storyteller will be here that you don't want to leave before these are over. And we have several storytellers who are in the audience right now who have given their wonderful stories in the past. So we'll end our day with that. But let me go ahead and introduce our next speaker. So Leila Amin is an occupational therapist who we stole or enticed or somehow convinced her and her husband to come to Seattle from Toronto. She was involved with several projects at Princess Margaret Hospital in Toronto, which you may know is it the largest cancer center in Canada? Yes. Yeah. And we hired her in the quality department because there was a lot of work that needed to take place, but she had this little side pocket that said, you know, I have something I'm interested in, which is the whole issue of how you interact with your work before, during, and after, which we almost never touch on, but mainly because we don't know it. As clinicians, we don't quite know what happens. It says except we write FMLA forms and sign, you can return to do this, to this activity, and that's it. And I think it's been very neglected, and certainly the support for patients in and around their work lives is a huge thing that really needs some discussion. And Leila comes not only with the passion for how to make a patient whole in their career, but also some of the investigations and science about how to study this in a way that I just found very unique. So fortunately, she's willing to speak to us on the topic, and it's a long title for that, and I'll let you explain the title and go ahead and give your talk. Do you want to use the lavalier, by the way?
I'll just speak in the microphone.
Okay.
That's okay.
Perfect. Thank you.
Thank you. Thanks very much for the kind introduction, Dr. Bird. I'm really excited to be here today. And I think I'm especially excited because I was informed that the audience today is largely comprised of patients and families and caregivers. So that makes it really, much more exciting for me. So I just wanted to kind of give you a bit of a roadmap for my talk today. I'll start with giving you a little bit of history around work and why it's so important for health. Then I'll talk to you a little bit about work and some of the statistics for oncology. And then I'm sure that there's people out there that probably don't know what occupational therapy is. So I thought I would give you a little bit of context around the role of an occupational therapist and what are the unique contributions of an occupational therapist on an oncology team. And then I'll talk to you a little bit about a return to work planning tool that I developed as part of my career at Princess Margaret Cancer Center in Toronto. And I'll share with you some of the research findings for the evaluation of that tool. And then I'll sort of shift gears and talk to you a little bit about the work that I started doing at the Seattle Cancer Care Alliance and kind of the different angle that I've had to take due to some of the differences between the Canadian and the US healthcare system. So why is work important? The World Health Organization has deemed work a significant determinant of health. So we know that it's really not just about work. There's much more to it. Work is so important for our psychological well-being. It helps us establish our self-identity, our self-esteem. Our relationships with employers and colleagues fulfill us and give us kind of gratification for moving forward. It's about being valued And for cancer patients, reintegrating into work can be one of the greatest predictors of quality of life moving forward in survivorship. Worklessness is the most costly disease faced by society. People that don't work generally have poorer physical health. They have an increased risk of feeling depressed. They lack social networks, and that loss of sort of social networks and social status is more likely to result in a dependency on alcohol or other maladaptive health behaviors, and so they're at greater risk for morbidity and mortality. So where are we headed in oncology? So I'm sure as much of the work in the morning alluded to, there are increased rates of cancer survivorship. We have more advanced treatments. We have more advanced combinations of treatments that are resulting in increased life expectancy for patients who were at one point perhaps diagnosed with terminal illness. These survivors are now living longer and longer. We have an older age of retirement. And so with that comes research that shows us cancer survivors are 1.5 times more likely to be unemployed versus healthy controls. So this is really an opportunity for us to think about what supports cancer patients and survivors could benefit from to increase their likelihood of being able to work throughout the continuum of life after cancer treatment. So the majority of cancer patients do return to work 1 to 2 years after treatment. About 20% of those patients do report some type of disability at follow-up. Most often that's late effects such as fatigue or chemotherapy-induced brain fog. The majority of patients who do transition back into the workforce typically do require accommodations. The most frequent accommodation requested is a change in work schedule. So maybe it's working less hours in a day, maybe it's working from home 1 day a week, that sort of thing. So I wanted to compile for you some of the predictors of return to work according to the literature. So age, the older you are, the more difficult it is to return to work. The cancer sites that are in parentheses are typically the sites that have more challenges when they're transitioning back to work. Length of sick leave, so the longer that you've been off of work, the more difficult it is to transition back into the workforce. And this theme is also evident for people that take time off for other reasons, such as people going off on maternity leave. So it's just the longer you're away from work, the more difficult it is to integrate back into. Disability insurance coverage. So if you don't have any insurance coverage or if you're self-employed, you're going to be more inclined to return to work sooner. If you have a desk job, it's typically easier to return to work versus those that have manual, more labor-intensive positions. This perception of your employer's willingness to accommodate, I actually found really interesting in the literature. So patients who perceive their employer as more willing to help, and this could be based on their experience observing other people transition back to work successfully and seeing their employer be open-minded and offering accommodations to others, is a known predictor of return to work. And lastly, advice from healthcare professionals. So if your nurse or your social worker or your oncologist is encouraging and takes the time to discuss return to work with you, it is a predictor of successful return to work. Top 3 concerns to return to work. And I have to say that these are not in the literature. This is based on my clinical experience working as an occupational therapist in the cancer rehabilitation program at Princess Margaret Hospital for about 5 years. I really found that in the patient population that I saw, anxiety was by far the biggest determinant for return to work. And so sometimes just having that kind of discussion and helping somebody think through the concerns that they have can be a really helpful thing to prepare someone for going back to work. I'm sure many of you can attest to the fatigue that can typically linger well after the end of treatment and sometimes can be even worse than you had during treatment, and then the chemotherapy-induced brain fog. I've listed a couple of the other common concerns below, so reduced strength, range of motion, neuropathy, lymphedema, that kind of thing. So I'll kind of shift gears a little bit and talk to you about occupational therapy. Just out of curiosity, a show of hands in the audience. Has anybody heard of occupational therapy before? Oh, many of you, wonderful. Do you know anybody who's worked with an occupational therapist in an oncology setting? Yep. Wonderful. That makes my heart so happy. So the way I like to describe occupational therapy to people who don't know anything about occupational therapy is I like to compare it to physical therapy because we do have a lot of common sort of overlapping skill sets. I'd say the one biggest difference is that as an occupational therapist, I'm also trained in psychosocial models of health. So there's a really big emphasis on mental health, well-being. There are occupational therapists that are trained in cognitive behavioral therapy. I think the other really distinct feature of occupational therapy is our focus on function and the impact of a cancer diagnosis or prognosis on your activities of daily living. So even things as simple as getting out of bed, transferring on and off the toilet, doing your grocery shopping. These are the things that are kind of really the crux of our profession. And so we, in the insurance industry, there are occupational therapists that are trained to do full-fledged job demands analysis, functional ability evaluations. And these are the types of insurance coverage where if you had an injury at work, typically insurance covers work evaluations that consist of these really thorough objective evaluations. This is the gold standard for return to work in industry. Unfortunately, for oncology patients, that type of coverage does not exist for return to work. So the research project that I'm going to describe to you was kind of created to offset the fact that we don't have insurance coverage. So what can we do kind of in a more succinct, consultative self-management model? I think that occupational therapists are skilled in the art of enablement. So we're trained to really break down your job into its component tasks and activities to help you figure out how you might want to prioritize or grade what you do when you go back to work to set you up for success. Any questions about that? No. And we'll definitely have time for questions at the end. So as Dr. Bird mentioned in the introduction, return to work, work maintenance, this is truly a gap in oncology care. It can be extraordinarily challenging for patients who can sometimes receive conflicting information from healthcare providers. There really is no one person on the healthcare team that is owning this issue. There's a lack of communication between all the parties involved. And sometimes this is also a result of just not having it to being part of standard care. So if a nurse makes a comment to you about return to work, they're probably not going to document that in the chart. So then the next person who comes in isn't going to see that. So it's not considered one of those like things that you have to address in each and every appointment. And so I have seen with my own eyes patients that are then left to rely on their own personal judgment for when to return to work, especially if they haven't had benefits. And this can kind of be a really tricky situation. So again, I'll shift gears now and talk to you a little bit about my work at Princess Margaret Cancer Center. So I just wanted to acknowledge that when I was an occupational therapist working in Toronto, I was a full-time clinician, and our hospital network had a program that was called the Collaborative Academic Practice Fellowship. And they believed that clinical people, point-of-care staff, are oftentimes very well equipped to understand the gaps in practice. And so this program was created to develop leadership skills in frontline providers and allow them to pursue a project they were really passionate about. And because I was working in cancer rehabilitation, I was seeing patients for other reasons. So they were coming to me for like problems with range of motion, problems with neuropathy, problems with fatigue, and work would keep coming up over and over and over again. And so finally I thought, I'm going to apply for this fellowship and see if I can develop some type of tool to support patients who are going back to work. And so this fellowship, basically what they did was they hired somebody else to take my role for 2 days a week so that I could be released from my clinical duties and start doing like leadership training, quality improvement training, and they gave me the support that I needed to develop this return to work planning tool, which I'll go into in a moment. So how did I develop the return to work planning tool, and what was the purpose? So when I saw patients in these other appointments, I would give them return to work recommendations, and they would always say, you know, is there a way that you could just write all of this down for me in some kind of like table, because I can't really remember, and I really want to have something that I can show my employer, or at least use as my speaking notes when I talk to my employer to kind of organize my thoughts. So I set out to develop this tool, and I did that by interviewing over 50 different key stakeholders. So I went to patients, I went to doctors, I went to primary care, oncologists, allied health people, people that worked in the insurance industries, human resources, occupational health. I even approached small and large business owners because I wanted to hear from them, like, have you ever had an experience trying to get somebody back to work who's been a cancer patient, and what was that like for you? So I developed a prototype of the template, and I went around and asked all these people to tell me what were their thoughts on the format, the content, the use, what would they change. And I kept doing this until it became like this circular thing where I was kind of back to the initial prototype. So I felt that I had reached saturation in terms of what new knowledge I could gain on the tool. Through that process, I learned a lot. So I just wanted to kind of walk you through some of the information that was kind of a byproduct of trying to develop this template. I learned that oncologists typically practice in a medical model. Their primary concern is curing your disease and saving your life. They are the ones that are asked to fill out disability forms. They oftentimes don't have the bandwidth to understand and learn what a patient's job actually entails, and therefore it can be really challenging for them to develop tailored work recommendations. I learned that patients typically have a very strong desire to return to work. They want to be normal again. It relieves their boredom, it increases their confidence, and they're also sometimes afraid of losing their benefits if they stay off work for too long. I learned that the employers don't know a lot about cancer. Unless they've had a friend or family member go through it, they know what they see in movies. And I had employers tell me that, you know, their employee took time off for cancer, and they basically thought it was a death sentence. And they went and hired somebody else to take that person's role after a couple months because there was no communication. They didn't know if that person was going to come back and in what capacity they would be able to work. They're very worried about people coming back too soon and for fear of re-injury, and then it's kind of their liability. So the message they would be giving their employees is do not come back to work until you are 100% better. They want to accommodate, they just don't know how. I really found the messaging that the employer was giving their employees around not coming back till they were 100% interesting, because that is really in direct contradiction to what I as a healthcare provider would recommend to my patient. I don't know that anybody ever goes to work at 100%. I mean, I think that I probably show up at like 80, 83, 84 every day. So, I mean, it's kind of like a marathon runner. If you know, break your leg or like tear a ligament, you're not just going to sit around until you're 100%. You have to kind of engage in this retraining. So I encourage my patients, if you're feeling 60%, let's figure out how we can get you back to work at 60%. So it's about empowering the patient to have that dialogue with their employer so that the employer also feels supported. So I thought I would share with you a case study of a patient that I saw in Toronto using this return to work planning template so that you guys can learn a little bit about the different sections and kind of what the process looks like. So Raj was a 52-year-old male from Pakistan. He had 2 daughters and a wife. He worked as a machine operator at a packaging company in Canada for 8 years. He was diagnosed with head and neck cancer, so of the left jawbone. He had a total resection and then received chemoradiation. He had been off work for 1 year when he came to see me. And in Canada, for patients who didn't have benefits through their employer, there's federal funding available to you, so you can get 70% of your pay for 15 weeks. But many of us know that the trajectory of cancer treatment doesn't always last 15 weeks. So when Raj came to see me, he actually wasn't receiving any income, and he had a mortgage to pay, and he had a family, and he just really wanted to go back to work as soon as possible. So a very strong financial motivation. The first part of the occupational therapy consult is really just around kind of understanding his work history. So who is his employer? What has his experience been with that employer? And these are the things that I document in kind of what I call the demographics section of the return to work planning template. Now, I will say that there are two versions of the template that I encourage patients to use. So anything you see on the screen right now with an asterisk, those are the parts that I tell patients, like if your plan is to give this planning template to your employer, I recommend that you delete those sections. But if you're just going to use it for yourself and for your own speaking notes, you can keep all of it together. I often found that last section up there, present issues impacting return to full-time hours and duties. That, for me, was a time when I could interact with the patient and just really feel this huge kind of like burden of relief from them, because when you have all the concerns in your head about why you can't go back to work, it's often this kind of like huge monstrous thing, and then just getting the patients to think about them and writing them down helps them realize that there's not really that much, and it also helps them remember what their concerns are, because sometimes when you have chemo fog, you can't even remember what you're worried about. So this I found was helpful for them in that regard. The next part of the template is around their job duties. And so I found in my practice that patients who are on gradual return to work schedules, so that might be going back to work 3 days a week and then, for 3 hours and then increasing it to 3 days at 5 hours and so on and so forth until you were back to full-time hours and duties. There was never any guidance offered for what is a patient supposed to be doing during those 3 days, 3 hours. So they would go back to work and their employer would have the expectation of them that they would be doing everything they were doing when they were working full-time. So this part of the template was really designed to help somebody determine what is their initial focus going to be when they're back to work on their gradual return to work schedule, and what are they going to be taking on once they're back to full-time hours and duties. And I would really encourage patients to have this in mind and negotiate with their employers and have the discussion so that the expectation is clear. I would also really encourage them not to take on additional tasks that were outside of the plan, because if they did that, my experience had been all of a sudden these floodgates would open, and then the fact that you had accommodations would kind of just go out the window and people would just keep giving you things to do. So I said, if you're feeling good and you can do more, that's great. Go home and spend time with your family, go for a walk, but try really hard to kind of like stick to this plan, otherwise you give a different impression. I found that it was really challenging for patients to kind of get started with this job duties section. So I would ask them to bring in their job description to kind of help get their memory going. And they would always say, oh, well, it's impossible. It's impossible for me to prioritize my job duties. It's impossible for me to decide what's an initial priority versus secondary priority. And then I said, okay, well, let's just try. And then we would kind of get going. And once the dialogue happened, they saw that, okay, well, my job duties can be kind of crystallized into these categories. And maybe there are things that I can like put off until later and things that I can start with right now. So this I found was the most important part of my work as an occupational therapist with them. The next part of the template is really around strategies. So I would list out the different strategies. And this was kind of, again, a self-management model consultation. So I would start this for them in the initial appointment. We oftentimes wouldn't get done. I would email them a half-baked copy of the template. They would work on it at home. They would email it back to me. We would kind of dialogue around it. And they might come back in for like one more follow-up appointment. So really focusing on giving the patient the tools they need to communicate. And in some sense, I think this activity is kind of like a work conditioning activity, because they're being given a task, they're being given a deadline, they're asked to work on it, send it back to me. So people said to me, even like the kind of working with you on this has proven to me that I am able to kind of go back to work and kind of carry out a task. So kind of a side benefit. And I won't go through all the different strategies. The next part of the template was around a communication plan. So I highly encourage the patient to set aside even 5 or 10 minutes a week with their employer to review the plan and make adjustments as needed. So sometimes if things are going well, you don't want to schedule the check-ins, that's fine. But just having something in the books is important, because if something does go wrong, you have an opportunity where you already have a time scheduled that you can have a discussion before things continue to get worse. A lot of times patients would say, you know, I haven't seen my coworkers for months and I'm going back to work on my first day and it's just so overwhelming. Everybody's asking me like where I was, how I was feeling, my hair looks different, and then by the time that's done, I'm just exhausted and I can't even work. So I recommended kind of having a lunch with coworkers, seeing them, going in for a team meeting the week before your actual start date, so that all those kind of questions can be asked, and then you can just go to work for your first day and hit the ground running. The last part is around disclosure. So this kind of came more from the employer's feedback, where they said, you know, my employee, John Smith, took time off for cancer and everybody's asking me where he is. And I'm just really unclear around what I can disclose. So I would encourage patients to have this discussion with their employer to let them know who can they disclose to, for what purpose, and that way it's just clear. And there are pros and cons to disclosure. So I would walk them through what are some of the advantages, why might you not want to disclose certain elements of your treatment and care. And I think they found it really helpful to have a plan and that laid out in their minds. We would also sometimes engage in role plays. So I would be the employer, the patient would kind of say something, I would challenge them back with a question, and I would help them practice on using a swivel technique, where if they weren't comfortable giving more information, they could kind of stop the conversation and go on to something different. So I wanted to share with you some preliminary data from our Canadian study around how this tool was being used. So we conducted qualitative interviews 2 weeks after patients who used this tool had gone back to work, so that we could understand, is this tool helpful and how is it being used? So the majority of patients who were part of our study had finished treatment less than a year ago. The majority were on long-term disability. Their age range was between 40 and 59. And we saw mostly breast patients as part of our cancer rehab clinic, and there was kind of a few other different diagnostic groups there as well. So the results, we heard loud and clear, using the return to work planning tool increased their confidence. Having a template that they could work on with a healthcare provider really added structure to their dialogue. It increased their knowledge. That knowledge and structure thereby decreased their anxiety to return to work. They told us that how useful the template was really did depend on kind of workplace factors. So whether or not they had supportive colleagues, whether or not they had a supportive employer, whether or not somebody else had been accommodated in the past. They also said that having an occupational therapist sign off on the template, and I would also get the oncologist to sign off on it, really added credibility to the tool and the recommendations. I wanted to share with you a quote from one of our participants, just because I think that it really speaks well to what we set out to do. So this person says, it was really helpful because I didn't just feel like it was something that I was making up. Having gone through a thoughtful process, it felt defensible because you are uncertain. You don't know how people are going to perceive or respond. It helps articulate things when you have it laid out in a thoughtful plan. So all the awareness that I was able to raise through using this return to work planning tool, I got support from our medical director at Princess Margaret and the program directors for the cancer rehab program to actually launch a return to work consult. So now instead of addressing this concern in other clinics, we had a specific dedicated kind of one-stop shop to address cancer patients' work concerns. The referral criteria for that clinic were being medically clear to return to some form of employment at any phase of the cancer journey, motivated to engage in a discussion about supports to go back to work, and having a pre-existing job before cancer diagnosis. That last one was important because there were so many patients that had pre-existing jobs that I didn't want the consult to turn more into kind of vocational counseling and like looking for work for the first time. So I had to figure out a way of kind of like scoping it so that I could serve people who needed it the most. So I'm going to shift gears again and now talk to you a little bit about the work that's happening at the Seattle Cancer Care Alliance. And so a couple years ago, my husband, who's sitting in the back over there, he came to support me today, took a job at Expedia, and we decided to relocate to Seattle. And I was really, really passionate about working in oncology. So for me, my career search was just really focused on getting a job at the Seattle Cancer Care Alliance, and I want to work as an occupational therapist. I learned after doing my licensing exam in Washington State that there actually weren't any occupational therapists employed at the Seattle Cancer Care Alliance. My role was in quality, and I had the pleasure of working with Dr. Bird on our Commission on Cancer Accreditation, and through our discussions, he learned that I had been doing return to work maintenance stuff at Princess Margaret and said, well, you know, let's try to see if we can get that happening for you over here. And I got approval from the VP of Quality to use part of my time to dedicate energy to starting a research project to see, well, how would this return to work service that was successful in Canada work in the US? And then I met a breast medical oncologist at a conference, and she was so interested in survivorship and return to work and quality of life. So the two of us partnered together, and I'm excited to say that we just finished our research ethics board application, and that was submitted last week. So we're just waiting for approval now to kind of start the same study in Seattle. So I'll talk to you a little bit about the rationale to pursue this in the US. So financial toxicity is kind of a buzzword here. Like even cancer patients who have insurance treatment, the co-pays, the co-insurance, it all adds up. And we hypothesize that introducing a work maintenance or a work reintegration intervention may reduce financial toxicity. OTs are skilled in providing this service in other settings, and we don't have a standard program to support patients in that regard at the Seattle Cancer Care Alliance. So what are some of the differences between the US and Canada? And this is kind of where I did a lot of learning when I came here and realized that in the US, there are a lot of cancer patients that maintain work during active cancer treatment. In Canada, because we have that federal income replacement, I would say the vast majority of patients took time off during cancer treatment. So for a breast cancer patient, for example, it was very common for them not to go back to work until 3 months after they were done radiation. And the breast medical oncologist that I work with now tells me that her patients are working right through active chemotherapy, through radiation, and sometimes do not take time off. So instead of focusing on return to work, we developed an intervention that was equally focused on work maintenance and return to work. And I would say the other really big difference is just health coverage. Like we have universal health care in Canada, whereas in the US, your coverage is really dependent on the employer, and you may need to continue working to maintain your benefits. So there's this huge impetus to stay in the workforce. So what are the study objectives for our work maintenance intervention? So we're first going to evaluate the feasibility and acceptability of an occupational therapist-led work intervention. We're focusing on breast cancer patients just for the pilot, so we get a sense of, well, are people even interested in doing this? What are the ramifications? What does it look like when you're encouraging work maintenance versus return to work? And I think understanding that and not just assuming that a tool that worked well in Canada is going to work here is really important to set us up for success. The things that we're interested in evaluating in our US study include perceived workability. So does that encounter with an occupational therapist improve somebody's perceived ability to do their tasks, which correlates with true workability and self-efficacy and confidence? We're going to be assessing their health-related quality of life, and we found a measurement instrument that can actually assess for the degree of financial toxicity. We're also conducting an economic analysis. So we're going to understand more about the cost of billing for OT services, how much we're getting back from insurance, and what are the out-of-pocket costs to the patient. So is this kind of a worthwhile investment moving forward? We're aiming to recruit about 30 patients, stage 1 through 3 breast cancer patients, working in a paid capacity, and we have some exclusion criteria listed here. We're going to do very much the same methodology as the Canadian study, so we're planning on doing interviews with people who use this tool 1 to 2 months after they have their initial occupational therapy consult to again understand like how the tool was helpful for them, how they used it with their employers. Were they just using it as speaking notes? Were they actually giving it to their employers? And then we're administering those measures that I talked about, the workabilities index, the quality of life measure, and the financial toxicity measure at the start of the study, and then 1 to 2 months after they've gone back to work. Future directions. So we're hoping to refine the intervention based on the results of our pilot study. We're going to expand to other disease groups and populations of the Seattle Cancer Care Alliance. And hopefully once we've established what the intervention should look like, we can conduct more rigorous studies in the future. So with that, I will be happy to address any questions anybody has or comments.
Before you get to questions, you heard this talk. I don't know if you were as blown away as I was. I haven't heard this extensive a talk before by you, but I felt like when I first met Leila, you know, the job we hired her for, the accreditation for Commission on Cancer Regulation, this is about one of the most boring things you can ask somebody to do, and it takes compulsion and really not missing anything and keeping people on track. And here's somebody who did this really well, but then it's like all of a sudden you've got this shell and this pearl pops out. And you go, wait a second. And then as she started talking more, I'm going, this is what you should be doing. I don't want you to stop the accreditation stuff because you do really well at that. But it was so clear that if you heard the breadth and depth that Leila's passion did in Toronto, and how much sense this makes for everything, including healthcare systems, the monetary side, the win-wins involved with that, the patient's confidence over the full integration back. This is such an important project. I'm hoping it's not just our cancer center, but this becomes a U.S. national model that you can lead on this. So when she was willing to talk to this group, again, this is not melanoma specific, but I'm positive that most of you in this room were hit or struck by many things that you went through yourself that realized you didn't get accesses or it's so clearly broken. And it just sounds so logical the way you put it up here. I just can't thank you enough for giving
My
that talk.
pleasure. Thank you.
Now, I do want to do some questions. Yes, question right there.
Thank you for this presentation. I'm really intrigued by it. I come from a background of HR for about 10 years, helping people return to work a lot. Also, I have a mental health background, so I'm helping folks through, counseling and those kind of things. And your presentation really touches on a lot of the things that the clients that I have who have just injuries, and they're all trying to get back to work. And so I have a lot of curiosity about you bringing this model both to the Seattle Cancer Care Alliance, but also how could other employees or mental health workers, for example, get in touch with using some of this type of model to help our clients as well. And I'm thinking also from the employer's side, I hope you have some sort of a plan to work with the larger employers at least to help them be receptive and start planning on using your tool. There's always a different level of people being able to understand somebody coming back to work. There's some folks who really have a very different level of expectation, and I just am really thrilled that you're doing this.
Thank you so much for your question. So I agree with you. I think there are lots of similarities between what a cancer survivor goes through to other kind of chronic conditions. I remember reviewing a lot of the literature in arthritis to develop or help me develop the primary kind of prototype of the communication tool, because you're still getting kind of like that episodic, chronic, lingering late effects, and fatigue. Fatigue is so huge. And I think that the way I can kind of get the word out there is by working really hard to publish some of this. So the development of the tool is already published in the Canadian Journal of Occupational Therapy, and I have a paper in press for the Canadian evaluation. And I know that the breast medical oncologist that I'm working with is very keen to ensure that our work that we do here gets published, and if we bring it on a more national level, it gets published. So I think we can't keep these things to ourselves. And thank you for your comment.
I have a question. I had stage 4 melanoma, which metastasized to my brain. I ended up with 4 brain tumors. 1 was removed. It's put me in a position where I'm on disability with really no prospects of going back to work because of many, many issues. Is there any consideration within this model to assist in the disability environment where I'm not actually going to work, but that is my work, because I'm responding to Social Security, which I can't do it with my brain. So I'm wondering if it's included in that.
Well, I haven't practiced clinically in the U.S. yet to be able to kind of speak to the nuances of dealing with Social Security. But what I can say is I remember a patient that I was working with at Princess Margaret who was, I think he was a palliative lymphoma patient. He was definitely palliative, and he was an architect, and he was a partner at this architect firm, and he wanted to work. And, you know, he was on long-term disability, and his oncologist, you know, told him, you're entitled to receive disability, like, don't worry about going back to work. But he just cared so much about being a partner at this firm. So we were able to negotiate a structure with his employer where he could kind of volunteer and go in and consult, but he wasn't getting paid, so that expectation wasn't there for him. And his colleagues weren't kind of burdened by his workload if he couldn't come to work one day, but he was able to still fulfill his passion by kind of being there in a volunteer capacity. So I think the tool has many different applications. In that sense, it was kind of being used to negotiate an arrangement where he could still go to work despite being palliative. And perhaps as I learn more about how the U.S. Social Security system works, there might be a purpose for the tool in kind of communicating. But I know from my work with patients that communication to insurance can be really tricky, because sometimes, I mean, they're not trained as healthcare providers, and they can sometimes approach things really aggressively and make you feel victimized. So I remember coaching patients constantly in my consults around how to have that dialogue with insurance and helping them to also understand where the insurance is coming from. So I think it's a great point that you're bringing forward, and something that I'll explore in the future for sure. Thank you for your question.
Was a rehabilitation counselor at one time, and I later prepared rehabilitation counseling and rehabilitation field. So, and what you're talking about in here, around here, in the United States, is usually done by the rehabilitation field and the rehabilitation counseling. And occupational therapy was one part of that, but the occupational therapists usually didn't control much. You just took over the whole thing. But I see what you're talking about. I call that rehabilitation counseling. Rehabilitation, yeah.
Yeah, and that may be a difference, again, in the Canadian and U.S. system. I know there is a vocational rehabilitation program at the University of Washington, and I've been kind of in touch with them to ensure that I'm learning about their service. I think one of the challenges for us at the Seattle Cancer Care Alliance is that some of our rehabilitation partners are located kind of across the way at the university. So sometimes it's just nice to have that service in-house, so that if a patient's already coming for treatment, they don't have to make an extra trip, and they're kind of amongst familiar providers. But certainly we wouldn't want to duplicate work, and I think that it's important to recognize and appreciate the perspective of the vocational rehabilitation counselors that we have at the university. So thank you for raising that. Any other questions? Okay. Thank you. Thank you for having me. Take care.
So I think this segues very nicely into what Kathy Sanders has got to present to us. Kathy is a nurse practitioner trained in family medicine and also has a master's in public health. And you have come, I think, with Heather Greenlee as a team to bring integrative medicine, integrative perspectives to care of cancer patients to the SCCA. And I think this will be, in this continuum of patient wholeness and how that fits into cancer will probably be what you're going to talk about.
Yes.
We're delighted that you're here. Do you want to use this or the lavalier?
I think this. Yeah. So, thank you. I'm really happy to be here. I think integrative medicine, I'm finding, is something that providers and patients either know a lot about or they've never heard about it. So I'm happy to talk about both our program and also where we think integrative medicine can add value within a lot of different departments, but also certainly in terms of developing a high quality life. And I really loved the presentation on return to work. I think it's so important. And I'm actually a cancer survivor of 10 years, and I worked at Columbia during my treatment in New York, and they were amazing. I was able to work just as much as I was able to, really maintaining that, and that really made a huge difference for me. But of course, working with patients over the last 10 years, knowing that that was very unique. And so I certainly want to be part of that program too. I think it's an important initiative. So thank you. So I've been a family nurse practitioner for many years. I did a 2-year fellowship with Dr. Andrew Weil's program in Arizona in integrative medicine, which I completed in 2007. That program is mainly physicians and a smaller number of nurse practitioners, but it's really driving what's happening across the country and really in parts of the world around this particular form of integrative medicine. I'm trained in a lot of different mind-body modalities, which is truly my passion. But my clinical practice here is really a full integrative medicine consultation. Recently added auricular acupuncture to my skill set. And yeah, so I'd like to, and I'll talk more about the pieces of the integrative medicine consult as we move along. And I was very honored. I had been actually brought on at Columbia with Heather Greenlee to start a program there. And they were excited, but they didn't really step up to the plate with resources. And Heather had been in conversation here for quite a long time with the idea of starting an integrative medicine program. And we had worked well together, so I made the move from Manhattan after 30 years to Vashon Island and Seattle. And if you hear an accent, I'm actually from Wisconsin originally, not from Manhattan. One of the exciting things about working with Heather is she is a nationally known researcher, and we really do want to do novel research here. One of the big issues for us as well as patients is a lot of the natural products and supplements really don't have the level of evidence that we need with human clinical trials. And so we're excited to have a focus on that. And I'm part of the research team as a clinician, but research is an important part of what we'd like to do. So I'm going to talk about the program, talk about how integrative medicine can be used in daily life, and then I hope we can have a conversation. I'm really interested in your thoughts on this and maybe what's helped or what's been confusing. So we know a lot of people are using complementary and alternative therapies for many years, and there is a way of collecting that data that goes on every year by the CDC. And we know huge amounts of money are being spent on natural products as well as other forms. And they use it for lots of different reasons. Some people really are using it because they think it will fight the cancer. Many people are using it for symptom management, which is the focus of our program, just to feel better, improve quality of life. Fatigue was mentioned as a huge issue, and in my experience, adding this can be very helpful for energy. And just to help with the stress of both the diagnosis, the treatment, and then the time after treatment. So what we want to do is create a safe space to look at what works, what doesn't work, and really look at the science so we can be a guide, but also have a space where it can be talked about openly. I certainly remember when I was going through treatment and I was doing a lot of these things, it was a very negative experience. The physicians and the nurses were very uncomfortable even talking about it. And so we do want to have a safe space for that. So the confusion around what are we doing, and it's different, I think, depending on what region of the country you're at. I mean, here there are very many naturopaths working, and that's something that people use, and it's an effective form of care for certain issues. But our form of integrative medicine is really bringing well-researched modalities together with conventional medicine, as opposed to going a completely alternative route. And also there are whole systems like naturopathy, homeopathy, traditional Chinese medicine, and there's overlap within integrative medicine and those whole systems. So part of the visit often is really talking about that and where people are at and what their intention is. So Heather and I are both part of the Society for Integrative Oncology, and this is the definition of integrative oncology, which is really, for us, interchangeable with integrative medicine. But it is patient-centered, evidence-informed, and that's careful wording because there are certain things like acupuncture that's been around for thousands of years that may not, for example, have the high levels of randomized controlled studies, but there is huge evidence for it for certain conditions, and it can be very useful, and it can be safe, just as an example. So we have a focus on mind-body practices because that does have good evidence for anxiety, for depression, for energy, as well as things like hot flashes and even peripheral neuropathy, pain issues can be helped. Lifestyle modifications, such as diet, exercise, and really looking at different traditions. For example, the anti-inflammatory spices, the curries, and really looking at different kinds of food that help with that process. And so what we want to do, and what I've been so impressed with here, is the providers I work with, they want all of this for their patients. And we're able to provide a space to really dive deeper into how do you optimize your health? How do you improve your quality of life while you're going through treatment or post-treatment? One of our hopes, too, is if we can help people develop a foundation of optimal health wherever they're at, is they may go through treatment more effectively or easier, and that could be an area of study as well. Also, empowerment and feeling like you have some control over what's going on with your body as well as with your spirit. So one of the big initiatives that Heather is very involved with in the Society for Integrative Oncology is developing these rigorous clinical practice guidelines, which is used within conventional medicine as well. And one of our missions, too, is not to be a standalone, off-to-the-side integrative medicine center. We really want to be part of the treatment team and work within each of the service lines as part of the team, contributing to the treatment plan. And I've worked in different models over the 10 years and helped develop 2 other programs. So I'm really excited about this. And we've been very welcomed by the oncologists, by the nurse practitioners, PAs, nurses within the service lines to do that. And my office is where I see patients is actually on a clinical floor. One of the things that goes along with developing these clinical practice guidelines is grading them. And so this is just an example of how meditation really is different mind-body practices, not just pure meditation. So things like guided imagery, mindfulness-based stress reduction techniques, even things like breath work that originally came from yoga practice. Music therapy, which we don't have here yet. Yoga, therapeutic yoga in particular, is something that can be very effective and that people can do really in bed. They can do it however they're feeling. So it can be a nice form of movement and exercise, and it has good recommendation and good study. Some of the natural products that people do come in often with very long lists of supplements and things that they've read about, that their family members who love them dearly have researched, friends, and lots of questions. You know, what should I use? What makes sense? I have people that were spending up to $1,000 a month on supplements. So part of our job is how do we kind of wean people down to something that makes sense and redirect into the areas that we focus on of nutrition, movement, sleep, support, and mind, body, and stress management. But I also will say I think there hasn't been a lot of money in the past put into that kind of research around natural products. So it's a very exciting time because more money is going into that. And there are certain products that are getting closer to reaching a level of recommendation, but they're not there yet. So we're not of the mind that you should just go off everything and that none of it has value, but we also want to do it in a safe way. Partly because a lot of these things haven't been studied with the conventional treatments, and they may interfere with treatment. And there have been products that actually caused cancer progression that seemed like they would be perfectly safe. And so we do it with that cautionary note of wanting people to do what's healthiest for themselves. A really exciting study that just came out, and Heather Greenlee was involved with this, did find a significant improvement in pain with women on aromatase inhibitors with acupuncture, and it's going to become part of the ASCO guidelines. It was actually featured in Time magazine, and so this is the kind of research that we're excited about, where they can demonstrate real evidence for complementary therapies. And we know in this particular instance, a lot of people go off of this medication that can be so useful in preventing relapse just because they're in so much pain and their quality of life is poor. So we came here in August and started building our program with really, and it truly was a wonderful leadership team. I spent a lot of time shadowing different providers, getting to know the culture and the people here, and working and figuring out how we can work together with palliative care, with nutrition, with physical therapy, chaplaincy, which is now going to be spiritual health, actually. They just changed their name to be more inclusive. And our team will include me. Dr. Greenlee will see patients during the week in a short clinic, but we will have a full-time acupuncturist and massage therapist who's also a therapeutic yoga practitioner and teacher and works with different modalities for pain and scarring. So two really talented people. They're starting in July to see patients. They're not on board yet, but they are hired. So that'll be our clinical team for now, though we do have a vision of a bigger team as we move forward. Our main focus is symptom management and improving quality of life. So really looking at what can people layer in to help with pain and to help with fatigue and pain, including peripheral neuropathy, certainly anxiety and depression. And that's been an interesting process in that we often work together with psychiatry, psychology, and social work with people that are dealing with that. But sometimes integrative medicine is a good place to start. And we can work with what are called non-pharmacologic approaches. And nausea also responds well to some of the techniques that we use. Sleep is one of my passions because it's pretty much ignored in a deep way. I think it's so complex because it involves our emotional health as well as our physical health. And helping people get to a point where they can have deeper sleep can be very healing. And I have the time to really dive into that particular topic. Always with the idea not that people need to let go of medication, but maybe they can minimize it. And some of the studies show that some of the mind-body techniques, for example, help the medications to work better for a longer period of time, including pain medication. Patients can self-refer, and anybody within the system can refer a patient to us, but they need to be SCCA patients at this point. And we are working towards working with the other satellite places within SCCA, and I've been really actively working with the telemedicine initiative that's going on because there's a lot we can do with telemedicine. And as everybody knows, the travel situation is challenging. So whatever we can do to reduce stress in that area, we do want to do that. So we're trying. And I already talked a little bit about the research focus. So what I'm really interested in and what I've worked with over the last 10 years is how can we be our healthiest self wherever we're at in the continuum. And so focusing on the things that do have evidence, which is how we're eating and individualizing that, some form of movement that makes sense wherever you're at. Sleep, I mentioned. There are some natural products that can be useful for some of the symptom management. And then using mind-body medicine techniques, which is a bit of a culture change because we're really thinking about this within integrative medicine as a habit to add to daily life. I always say it's like brushing your teeth. It's something, if you start to do it, you will get a training effect from it. So those are our areas of focus. And I often wait till the end of the visit to talk about the idea of being kind and compassionate with ourselves as we move through our daily life and as we add changes. And I also talk about perfectionism because people sometimes think, well, if I just eat the perfect diet from now and forever, ever, amen, the cancer's not going to come back. And sometimes that just sucks the joy out of the day. So I talk about the 90-10 approach. Food has meaning. It's not just about eating vegetables constantly and maybe throwing in a couple of fruits. So that's an important part of my visit too, is to be kinder with ourselves, more compassionate, build a high quality day. But the day needs to feel joyful when you're able to have that, or at least neutral. And there needs to be a sense of relaxation within it. And humor, of course, is very important. So I do mix those pieces in, and they do have some evidence, actually. So food as medicine, and this is something we work really closely with our medical nutrition department. And when I interviewed, initially it was just wonderful because we have a very similar philosophy. But I'm not a nutritionist. What I really do is help people strategize about making their approach to eating more anti-inflammatory in a delicious way. And there's part of our fellowship, Rebecca Katz wrote The Cancer Fighting Kitchen, which has a lot of great information on anti-inflammatory spices and great recipes. And there's a lot of good books out there, but that's one that I particularly like. And she looks at the evidence. I think one of the big issues with eating for many people is it's very hard to change our eating habits. Sometimes at diagnosis, fear can drive a certain way of eating to being, extremely healthy. As you move down the road, that sometimes shifts right back into however we ate before the diagnosis, because we're human beings and changing what we do can be very challenging. I'm trained in mindfulness-based stress reduction, and an offshoot of that is a mindful eating program that I'm trained in and have worked with. And it's actually a lovely program, and it's something you can add to making small changes in how you're eating so that it can be sustainable and lifelong. So exercise and movement is always an interesting area because I think sometimes people feel, I'm so tired, I have a lot of pain, I really can't do it. And so working with therapeutic yoga and working with some really gentle movement actually can be very helpful. It's things people can do even in bed or in a chair. And then for busy people, it's like, what's the minimum thing you can do? Even if you're having a very busy day. And we know getting at least 30 minutes of gentle walking in, doing some stretching, and then adding in some light weights for most people is doable even in a busy week. And the research is very solid around its effect on the body and on the cells and in preventing cancer relapse. So with a lot of the work that we're doing, it's how are we nourishing the healthy cells in our body? Step by step. And that can feel good when we layer it in and think about that. One of the physicians I worked with in the fellowship, he said it's like a garden, you're just nourishing that garden and feeding it what it wants, whether it's the movement, getting good sleep, or the food, or laughing, or hugging, all those pieces really help the body. And I talked a little bit about sleep, but the impact on the hormones and the inflammatory process in the body is quite profound. And it's also hard to change sleep habits, but it is doable. And it's something I've worked with people on for a very long time. And the mind-body medicine techniques can be helpful, even just simple sleep hygiene. If you can take a bath with Epsom salts, and lavender aromatherapy actually has some good evidence. Rubbing it on your hands and feet can be very calming. So there's some simple, sometimes even a little folky things that you can add to improve how you're sleeping as you go into sleep. And I do work with teas. Teas generally are safe. So there are things like lemon balm tea, chamomile tea that can be very calming. So we do use some natural products in conversation about different symptoms and how it can help. So I've actually been pleasantly surprised. I was always worried, if I talk about this, that people are going to be very upset. They really want a pill or something that they can take to fight the cancer that they feel is safer or more natural. But in general, I'd say people really get that the other things I've been talking about are important and that they do want to do what's safe for themselves. But it can be very seductive, the things on the internet, the different programs that are offered. And so it's been really an honor in a way to really look at the science about the supplements with them. And then in the end, I think we all make our own decisions about how we want to move forward. But I think the big thing is transparency, a good conversation, and knowing where things are at. And then patients, we all make our own decisions. But it's good for the team to know what's going on and how we can help. So the mind-body medicine arena has been studied a lot over the last 30 years, and certainly before that. And the effect of starting to do some of these techniques as a daily practice on the centers of the brain that deal with anxiety and depression, and also the impact on pain receptors and bringing the inflammatory process down in the body. Some studies show that there may be an immune boost with doing some of these too. The bottom line with mind-body work is that it's safe for almost everybody, and something that can be added. I had a woman 2 days ago come in with very high blood pressure, and she was really interested in learning a technique, and I worked with guided imagery, and it came down from 170 over 90, and it went down to 130 over 70. So it was a nice immediate response. To get it to really work, though, as a long-term piece of the treatment program, it needs to be practiced consistently. And that's probably the hardest part, is adding in something new to the day. But it's a good tool, and it can be helpful in the arena of pain. And I've been brought on to the pain team, and we're adding it hopefully more often now at the beginning of treatment, but certainly with people that are running into a wall with their pain medications. So, and once we get our acupuncturist on board too, I'm really excited to add both the acupuncture as a primary and then bringing in the mind-body piece, because it can be very helpful. And therapeutic massage actually can be too. That said, the other issue that we're dealing with as a program is billing, and how do we bill for these modalities that aren't traditionally covered by insurance. And it's an area that our team is working so hard on, because we don't want this to be a two-tiered system. If somebody will benefit from a technique, we want to be able to offer it to them. But it's a work in progress. How much time do I have? Has anybody here heard of Herbert Benson? Yeah. So he's one of my heroes. I mean, he really introduced the idea of the relaxation response, which was studied actually in Harvard, at Harvard and at the medical center in the early 1900s by Dr. Cannon, who developed the phrase fight or flight and studied the physiology of what happens to the body when we're under stress. And one of the things that I talk about, and it's a bit simplistic, but when we're stressed, whether it's just the normal stress of everyday life or the news that we're hearing or dealing with treatments, we're literally walking around like a car with our foot on the accelerator all day, and it's just really burning up the system. And so these techniques can help you lift that up a bit so the body can stay in a healthier place. It doesn't get rid of the stress. I wish I could do that, but it does help you keep your body in a better place. So I wanted just to do 3 of the fundamental techniques with you if you're up for it. If you're not, you can just watch, that's fine. And they're simple, and they are things that you can do pretty much anywhere, and you can do it throughout the day. So I'd like to teach you one really simple breathwork technique, and then the lemon exercise, which will be explanatory once I do it with you, and then passive progressive muscle relaxation, which takes about 5 minutes, and I found it's a technique that people can do even if they're very busy or just to get a start with this kind of work. So what I'd like you to do is get yourself in a comfortable position, best that you can in the chairs, though these aren't too bad. And feet flat and hands on your lap. And then you can close your eyes if you're willing, or just gaze ahead. And I'd like you to put your hands on or one of your hands at least, on your lower abdomen. And then we're going to do what's called soft belly breathing or diaphragmatic breathing. So breathing in through the nose all the way into the lower abdomen, and your shoulders should stay pretty still, and then breathing out through your mouth. So we'll do 3 of those together. So breathing in and breathing out. Breathing in, breathing out. Good. And then breathing normally. You can keep your eyes closed. I'd like you to imagine yourself standing in a kitchen by the counter, and there's a beautiful basket of lemons, big, plump, yellow, juicy lemons. I'd like you to pick up one of them and place it on a cutting board, and take a little paring knife and cut it into 4 juicy chunks. And then I'd like you to pick it up and bite into it and smell the lemony smell and taste the juice. Okay, and then you can open your eyes. So, did anybody experience anything? Yeah. What? Salivary glands? Good. Me too. So it doesn't work for everybody, but so there's no lemons in the room, and the brain-body connection, which is what a lot of the mind-body work is really about, is helping you reconnect throughout the system. So this next, this muscle relaxation technique that I'd like to do with you is really working with that. And so if you could get back in your comfy position, your hands can be anywhere now. Good. And let's start with a nice breath in through the nose, into the belly, and out. Good. And then breathe normally. So I'd like you to begin to focus your attention just on my voice, with your eyes closed and your body as comfortable as you can make it. So any thoughts or feelings or sensations, external noises, anything else that presents itself, I'd like you to acknowledge it very gently or kindly or neutrally, even the difficult ones, and let it drift off to the back of your mind. Or you can imagine it floating away on a balloon or a cloud, whatever works for you. So taking a nice deep breath into your lower abdomen. As you exhale, feel your whole body letting go. And taking another nice deep breath in. As you exhale, beginning to feel sensations of relaxation entering the various muscles of your body, and really beginning to feel more and more comfortable and more at ease. Breathing normally now, bring your attention to your forehead. You can feel those little muscles stretching out and relaxing. And then allow that relaxation to move over your eyelids, over your nose, into your cheeks. Just let your cheeks hang limp with relaxation. Into your jaw and your tongue. Just allowing your jaw and your tongue to hang slack with relaxation. Even the tiny muscles in your scalp are loosening up and relaxing, so that all the muscles in your face and your head are more relaxed and comfortable, more at ease. Bring your attention to your neck and shoulders, letting any tension or tightness that's there dissipate. Let it drift away. Muscles in your neck and shoulders now are more relaxed, comfortable. Feel that relaxation moving into your chest and stomach, diaphragm and abdomen. Feel that relaxation moving from the base of your neck all the way down your back. And from your shoulders all the way down your arms, into your hands and fingers. Just imagining any tension or tightness that's left just flowing out the tips of your fingers. Feeling that relaxation moving now into your hips and all the way down your legs. Your thighs and knees, calves and ankles, your feet and your toes. Just imagining any tension or tightness that's left flowing out the bottoms of your feet and drifting away, so that all the muscles in your body are relaxed, comfortable, and at ease. And then take a moment to notice the silence that's there. The more you're aware of that silence, the deeper and more healing your relaxation becomes. So in a moment, I'm going to count from 1 to 5. At the count of 5, you'll open your eyes and you'll be alert and awake and refreshed and relaxed. But I'd like you to take your time. So 1, take a nice deep breath in, waking up a little bit, and 2, move your fingers and toes if you want to, waking up a little bit more. 3, waking up more and more. Another nice breath in. And feel that relaxation coming with you. And 5, open your eyes when you're ready, alert and awake and refreshed and relaxed. So does anyone want to share how that felt? Relaxing's good. So it's a simple technique, only a little over 5 minutes long. And I'm sometimes sort of taken aback by how well it can work. I had a woman with really severe pain issues that came in, and these are the techniques I usually start with. And she was kind of curled up on the table, and her daughter was there. She was 47, and we did this. And she just looked up at me at the end and smiled, and it was the first time she hadn't had constant pain in a long time. And of course, it came back as she got up, but the idea of starting to practice this was very engaging. And so that's a simple, gentle, very safe part of integrative medicine that we can help build in to the day. So thanks for doing that. This guided imagery really just adds images to this process that we just did. What they found is the brain relaxes when you do this, and you can, sometimes in the tsunami of all the challenging negative things that are going on, bringing in a beautiful image when they do functional MRIs has a really profound impact on the Centers for Anxiety and Depression. And they've done some wonderful studies even with people in nursing homes around this. So we can work with guided imagery. Mindfulness-based stress reduction, John Kabat-Zinn started studying that about 30 years specifically for pain and for severe pain. And it is a challenging technique to learn, but once you learn it, it's very, very useful both for the physiology of pain, but also learning the ability to shift awareness away from painful areas, for example. So it can be used as a tool in a number of ways. And these are just some of my favorite resources, certainly not an extensive list. Dr. Richie Davidson at the University of Wisconsin-Madison has been studying the monks for over 30 years. He's a neuroscientist and was really considered, an outlier doing woo-woo stuff, and now he's very honored for this work that he's done. So he is one of my heroes, and John Kabat-Zinn also. So there are some good resources out there to help build some of these practices. I do this too, but I'll have people put a mindfulness bell app or a timer on their phone just to remember to breathe during the day, because sometimes you get busy and you forget. You can do 3 soft belly breaths and get yourself to center, and that is healthy for you. So thank you for having me, and I'd love questions or thoughts, and healthy skepticism is always encouraged, so.
So Kathy, thank you. Maybe I'll just start things off for a second, pull this over.
Yeah.
So mindfulness is something that I think we need to be so constantly aware of. I'll give you an example of the opposite of this. I went to the Mariners game last night. It was my stepdaughter's birthday. She's 26. Her girlfriend and a boy friend of hers were there with my wife and I. And so, I don't know if you saw the game. It was a very good game. The Mariners won, but it was an exciting game. The whole time during the game, my stepdaughter's friend was on her phone. Almost the whole game. She was on it a fair amount, and the guy friend was kind of in his own world with the fans, and I'm just thinking, this is the opposite of mindfulness going on here. If nothing else, focus on the game, at least. It's a great game. But I guess my question is more of a societal question for all of us. The concept of multitasking, I'm becoming a big believer that it actually cannot exist well. You're not doing anything well if you're multitasking, and I'm seeing less and less value of that. You're checking off little tasks, but you're usually doing something real time that you would have done at a different point in time and focused on. And I just see our society, and especially our young people, bombarded by noise, by flashes, by sound bits, by behavioral norms that have changed, are changing dramatically. And maybe you and anybody in the audience have some thoughts about how we can work. These are things we can do for ourselves or those around us, but any ideas about how we can work with the way that technology and society are going? Because I don't see mindfulness very often at all. And an elevator, how many times have you been in an elevator? There's 6 people in an elevator. No one looks at each other.
Yeah.
No one says hello. They're either they're uncomfortable, so they're on their phone, or they're just
Right.
like this. And it's kind of the opposite of the connectivity that I think draws us together.
Great. Yeah, no, this is an area that I'm so excited to talk about too. And I first studied this at Barnard when it was in the early 90s when I did my own 8-week course with mindfulness for myself. And they were renovating the floor that they were teaching it, and people were like really upset. And the teacher's like, no, this is a gift. You know, you're going to learn to let go. You're going to learn to let go. And we did. I think one of the things that we know is that human beings spend really most of their day living in the past or thinking about the future. And when we do that, it really impairs, as you were perfectly describing at the game, this ability to connect with the people that we're with. We miss out on the good stuff often because we're so busy worrying or thinking or planning. I love making lists, you know, going off and making a list in my head. And we know that busy brain is part of this overload for the body's physiology too. So learning to be more centered is something that's just given me, number one, more joy in my life because I am able to do that more often, and I think that's what I like to share with the people I'm working with. But it also turns us into better responders rather than reactors. And so certainly in the workplace, that can be so important because there's just so much going on. It can help you step back and really either not respond and wait or have a more thoughtful response. But I think just quality of life. I know the phone for me is addictive, so I know I purposely put it away now. I get to take this beautiful ferry boat ride from Vashon every morning, and really most of the people are on their phones out as Mount Rainier goes by, you know, and I'm like, this is so beautiful. And it actually was worse in New York, believe it or not. And we were in Canada near McGill University in this beautiful park. This was a couple of years ago, and nobody was on their phone. So I've always wanted to find out, is that like a cultural difference? And these were students and everybody, but I think we are doing ourselves a huge health favor and quality of life favor when we think about that. But also knowing mindfulness is something that isn't easy to learn. It takes a gentle discipline. You know, sometimes people say, well, I'm going to eat mindfully, you know, and they do it once, but it is something you can learn to do with me or online or with other kinds of courses. So thank you. That was great.
By any chance, does anybody have the other microphone? It went missing somewhere.
Do you want this one? You want to use this?
Yeah, I'll do that. Oh, here it is.
Oh, sorry.
I'm the one that lost it.
And I didn't see it.
Right. My question is, could you define what you mean by centered? Because I hear this word used a lot as though we all understand what that means, and I don't.
Good question.
Thank you. Thank you.
So the sense of centeredness really can be created by coming into our body. And the yogic breath work is helpful in the moment coming into the body. practice of it allows us, when we get thrown off center, to come back more easily to our breath, our body, our minds. So that's how I think of it. It's really this idea of presence, and I mean, certainly physically being centered, I think, can support that. So the more our bodies can hold us as best we can in a centered way, it can reinforce that. But my thoughts about centeredness have more to do with our spirit and our brains. And I think the other thing that maybe goes along with this is we're not talking about people becoming zombies and just constantly, in the zone. We need to plan and think. And I used to make a deal with myself when I was running. I could think and plan because I was, creative during that time. But then I would go into a sense of centeredness and being present as I was doing that. So I don't know if does that answer your question? I think it's an interesting, very thoughtful idea to be explored.
We can do a breakout session for that next year. Any other questions?
I have a quick question. Prior to getting scans, my body just falls apart. My head starts hurting, my legs falling off, and all this kind of stuff. And then I go in and I get my scan, and on a good day, it's a clear result. And 2 hours later, I'm completely healed. Do you have, I'm sure some of the other people have that experience. Do you have any comments on that or correlation between the psychosomatic syndromes and that stuff?
That's a great question. Yeah, so actually one of the things that I work with is a form of guided imagery that can be done pre-procedure, pre-test, pre-surgery. And it works with that idea of putting because often when we're that anxious, it's the unconscious that's in the driver's seat, not our executive functioning skills. Because that part is like, well, it could be good, it could be not good. And what you're experiencing, of course, is happens to all of us really before these tests because it's really challenging. But the guided imagery can help. This idea that I can go through this in a calm, centered place. I can take care of myself as I go through this. If you want to. I mean, sometimes we just let ourselves do that. And doing that for a little bit is sometimes okay. But if it's interfering with your life, the guided imagery practice could be useful for that too. It can be empowering.
Great. Thank you very much.
Thanks.
Okay, there will be nap cots put out here for everyone. You've gotten us so relaxed, and that was wonderful.